So I want to thank the organizing committee and especially Sophia for the invitation. And I'm going to talk about the sex inequities in sleep disorder breathing. And sex inequities refer to systematic differences in opportunities, in resources, in outcomes between individuals based on their sex or gender. And these inequities can manifest in various aspects of life, like healthcare, education, employment, social participation, and women and girls are those who are facing usually these disadvantages. And when we come to healthcare, you saw for example, in presentation of Esther, that women are often underrepresented in medical research and in clinical trials. And this leads to a lack of knowledge about their specific health needs and potentially their health outcomes. And in some cases, women also may face barriers in accessing healthcare services and may experience disparities in treatment. And when we talk about sleep health inequity, it is defined as a difference in sleep characteristics based on the race, gender, and socioeconomic status. And when we talk about sex inequities in sleep, these involve differences in sleep patterns, in sleep quality, in sleep disorders between men and female. And of course, we have seen that women report more frequently poor sleep quality. They're more likely to be diagnosed with insomnia. And on the other hand, men are more likely to be diagnosed with obstructive sleep apnea. And these differences are influenced, as I will show you in the following slides, by biological factors like hormones, but also they're affected by social and lifestyle factors. And you can see here that hormones play a very important role in women's life, and different periods of women's lives and different hormones affect their sleep, and of course the changes in their sleep architecture. And of course, as the time passes from newborns and in different phases of women's lives, like pregnancy, menopause, and of course aging, there are differences in hormones, difference in their biology, and they undergo numerous changes in their sleep, and of course sleep disorders. And even in our reproductive phase, we have differences in our sleep that are closely related to the different hormones, for example, during our menstrual cycle. So these differences in sleep are being more and more complicated. So I'm going to refer only to sleep disorder breathing. However, there are differences between gender in other sleep disorders like narcolepsy, like restless leg syndrome, like insomnia, but I'm going to refer only to sleep disorder breathing and especially obstructive sleep apnea. So obstructive sleep apnea has been considered a male disease. You can see that the male-female ratio ranges between 1.5 to 5 in the general population. However, recent research has found that around 27% of men and 22% of women suffer from the disease. And it seems that the disparity of sleep apnea prevalence between genders narrows with age, with women facing increased risk of sleep apnea during perimenopausal and menopause. So this suggests that sleep apnea is not a very rare disease in females. And of course, there are different pathophysiological factors that influence these gender differences. And of course, women are protected before menopause, before they have higher levels of progesterone, estradiol. Their disposition of fat is mostly peripheral. They have low, shorter and less collapsible upper airway. And when the year passes and women enter to menopause, all these protective factors seems to decrease or even disappear. And this is from Dr. Bossignor's paper about the differences between genders and the female characteristics about females, and these are the pathophysiologic features that are unique to females with obstructive sleep apnea. And it seems, as I showed you before, that the upper airway is less collapsible. We have shorter airway length, which increases with age. There is a lower critical closing pressure. Of course, the deposition of fat is peripheral. And we also have lower chemioresponsiveness, lower metabolic rate, less respiratory drive instability. The progesterone stimulates ventilation, and premenopausal females also have a lower hapnoic threshold. And this is from Esther's paper. I think it's a very nice paper, and with very nice figures. And you can see that these endotypic features change over time in women. Of course, they are different between men and women. And of course, in women, premenopausal women have a lower arousal threshold that change over time. Post-menopause, there is a higher collapsibility of the upper airway and a lower muscle responsiveness. And men have, of course, higher collapsibility of the upper airway, higher loop gain, and ventilatory instability. So the sex inequities in sleep disorder breathing, do women need a different approach on diagnosis, on treatment, and also what about comorbidities? And of course, we have talked about the different symptomatology of women, and sometimes women do not show the most classic symptoms of obstructive sleep apnea, and there are more complaints about insomnia, about headaches, about restless leg syndrome, about depression, lack of energy, nightmares, and of course, for this, they are underdiagnosed. And we all know that women come to our clinics alone without their husband with them most of the time, and the different happens when a man comes, often with their wives. So we don't have a witness of what happens during the night of a woman. And it has been found also that women with sleep apnea have higher healthcare consumption, and more frequent physician visits and hospitalization before the diagnosis of sleep apnea. And women with symptoms of sleep disorder breathing are less likely to be diagnosed and treated for sleep apnea compared to men. So it's up to us, the medical care providers, to suspect and diagnose female patients. And of course, sometimes it's important to consider the sleep fragmentation during pregnancy or menopause could be secondary to other factors apart from that. For example, the increased reflux during pregnancy and also the vasomotor symptoms and night sweats in menopause may be misleading features of sleep apnea, and someone may think that these symptoms are caused from pregnancy and menopause and overlook the presence of sleep apnea. And you can see that the symptoms in women are different, and here you can see that sleepiness is reported mostly from women, even in a very mild disease. And you can see with orange is the excessively sleepy women from that part of the figure, and here are the men in mild disease. So women express more their sleepiness, and of course we go to different clinical phenotypes. We all know that sleep apnea is an heterogeneous condition, so there are several studies that phenotype different specific sleep apnea subgroups in order to promote the more personalized medicine. And these studies use different combinations of clinical symptoms, of comorbidities, of sleep indices and anatomical characteristics. However, very few of these studies target specifically women. And here is one of the first studies about phenotyping, the ISAC, and you can see that in pink that 80% of the patients were men. So here we come to the ASADA database that we have also performed. You can see it's a large number of patients, 23,000, the clustering of these data, and you can see that some phenotypes were only men, sometimes in both genders, and some in women. So what we wanted to do in the ASADA in the next step was to take around 30,700 patients and include only women. 30% were women. So we have performed a cluster analysis on these women, and we found different clinical features of the disease. And you can see that the class 1, this in green, was the most prevalent feature, that was women with ischemic heart disease. Of course, we had the sleepy obese women, the most classic clinical feature presentation of sleep apnea, women with no with less comorbidities and not sleepy, and the elderly women with comorbidities. And not only in the SADA, but other groups at the same time performed this analysis. And this is a single center study from Spain. And as you can see here, the most prevalent clinical phenotype here was that with the most classic symptoms of sleep apnea. So sleepy women, more obese, middle-aged, with cardiovascular risks. So there are sex inequities in sleep disorder breathing also in the polysomnographic findings. And we know that women have lower apnea-hypopnea index, less severe desaturation, more partial obstruction of the upper airway, more respiratory related arousals and shorter apneic events, and they present more apneas during REM sleep. And this is very important because this REM OSA has been associated with cardiovascular disease, with hypertension and early signs of atherosclerosis. And women have lower non-REM apnea-hypopnea index, that this is the one that we treat. So sometimes they don't receive treatment for their REM sleep apnea. And it seems that when we try to diagnose women, probably the effect of these problems during their REM sleep may explain why they are symptomatic at lower apnea-hypopnea index compared with men. Of course, when we use PG and not PSG, we don't have these REM episodes, and also we don't have RERA. So women do not have less sleep disorder breathing, but probably we don't use the right tools and right scoring criteria to diagnose them. What about questionnaires? That was an older study of our center, that we compared different questionnaires, men, women, and the predictive values were completely different between men and women. So probably we need more specifically designed questionnaires for women. What about comorbidities? It seems that comorbidities like asthma, like thyroid disease, depression is more common in women. As you heard from Esther, there are high adverse cardiovascular consequences, and especially in women. And this is a very recent study that has found that parents saw similar comorbidities to their children with sleep apnea. And it seems, as you see in red, that maternal obstructive sleep apnea was very closely associated with childhood sleep apnea. So if we diagnose women, mothers with sleep apnea, we could prevent the adverse outcomes of sleep apnea in their children. And this is the impact of cardiovascular outcomes that we talked in the first presentation of Esther about. It has been found to be greater in women than men, and when it is assessed by oxygen desaturation, but not apnea-hypopnea index. And here is the study that Sophia was talking about, that sleep apnea was associated with increased risk of long-term cardiovascular events following an acute coronary symptoms, particularly in women. And here you can see the whole population. This is the first figure. The red is the one with sleep apnea. You can see women, and here you can see men. And more specifically, if you see here, here are women that were hospitalized with unstable angina. The red is with sleep apnea, blue without. And here are the men. And of course, the women with revascularization ischemia driven to the hospital. So it seems that the effect is greater in women. So this is a very recent study about the long-term consequences of sleep apnea and the influence of gender. It's a Danish study, and they compared men and women with sleep apnea, and they matched 1 to 4 with controls by age, sex, marital status, and the community location. And what they found, and you see that it's a large number of patients, they found that there is a great clinical and socioeconomic burden, like the higher mortality, the higher morbidity, the healthcare costs, the social consequences in patients with sleep apnea. And it seems that this effect has been found even 15 years before the diagnosis of sleep apnea. And of course, this effect was more significant in women compared with men. What about treatment? Of course, treatment with CPAP can improve the sleep quality. It reduces snoring, decreases daytime sleepiness, and improves the overall quality of life in women with sleep apnea. And it can reduce the cardiovascular adverse effects of the disease. However, women, as I told you, appear to suffer more frequently from REM-related sleep apnea, so they have to use their device for more hours during REM sleep, so they needed a longer nocturnal duration of the disease, and often they are not treated only for that REM sleep apnea. And women have less pressure with the same sleep apnea severity in their device. So it seems that women may experience different symptoms and different challenges with the CPAP compared with men, and they are more sensitive to air pressure and have greater difficulties in the initial setup and adherence of the device. And of course, for the adherence to the CPAP, there are different studies, different results. However, a very recent study has shown from the French database has found that females do not really have a higher termination risk of the device. And of course, there are CPAP devices and CPAP algorithms that are more specially designed for women in order to achieve lower pressures and also have algorithms that respond to REM sleep. And this is a study that has shown that younger age and female sex that has a really correlation with the adherence to the device, and women of younger age do not really respond to treatment. However, when the year passes, it seems that adherence is better. So we have to have a special care to treatment follow-up according to age and according to gender. Other treatments like mandibular device seem to be more effective in women, like weight loss seem to have a better effect in men. And very recent studies, but not very conclusive, have seen that the GLP-1 receptor agonists may be better may have a greater impact in women, but few studies. What about COMISA? It's more frequent in women, so it seems that we should have other treatment options in women with COMISA, like cognitive behavioral treatment. And these are the last 2 or 3 slides of my presentation, and I will like again to thank Esther about this table, because it summarizes the sex inequities in sleep disorder breathing, and it seems that the diagnosis and treatment in women requires a specific consideration, like the screening questionnaires, like the different symptoms, like the different sleep measures, like the REM, isolated sleep apnea, or the non-desaturation sleep apnea, like the upper airway resistance syndrome. And sometimes the sleep fragmentation and symptoms like insomnia may be undertreated for sleep apnea. And of course, the clinical phenotype, special questionnaires, and also sleep study scoring, especially for women, probably could help. And of course, as the year changes, we have different. Sex and gender is different. So sex is biologically set. However, sex can be changed, and there are people that change their sex because gender is culturally defined. So probably with the hormones, if a woman takes testosterone to change her sex, probably will have different problems concerning sleep and the opposite. So we should have that into our minds. Individuals, it's possible that all of us are different individuals, so it's possible that sleep apnea is not presenting the same in all of us. So it's not only by gender, but in different individuals. And when a woman comes and seeks for help in a sleep clinic, it seems that she has symptoms. So it's very important for us to take care of her and assess further and think of potential differential diagnosis. Thank you.